My name is Neil Riley. I'm from Sheffield Teaching Hospitals. My colleagues, Claire Riley, who you've seen earlier this morning from Northumbria Healthcare Trust, and John O'Brien from Care UK. Sadly, the three chief executives of our organisations are not able to be with us today. With the permission of NHS England, they have made a DVD, which you will be seeing very shortly indeed. Showing my age, there's an element, I think, of earth, wind and fire about this. So rather than cricket analogies, if you wish to work out which one is which, please feel free to do so. But if we can show the DVD, and then clearly we'll take any questions.
I'm Andrew Cash, Chief Executive of Sheffield Teaching Hospitals NHS Foundation Trust. I'm part of the Hospital Futures Partnership, a joint venture between Sheffield, Northumbria Healthcare NHS Foundation Trust and Care UK. We want to use our combined expertise to create a hospital chain, not inside a local area, but across geographies, ensuring the future of high quality and sustainable local hospitals. We don't believe one organisation has all the answers to this challenge. That's why we have created our partnership, combining the capabilities of an award-winning teaching hospital foundation trust, the country's most successful integrated trust, and the largest independent provider of NHS health and social care in the UK. Working together as the Hospital Futures Partnership, partnered with one or more local hospitals, we can create a chain which supports local clinicians and communities, securing the future of valued local hospitals. This happens internationally, but it's a new idea in the NHS. Here's Jim Mackey to explain more.
Thanks, Andrew. I'm Jim Mackey, Chief Executive of Northumbria Healthcare Foundation Trust. Andrew's right. In the NHS, we usually believe local mergers or integration are the only solution. And they often are the right solution, something we know from our own experience in the North East. But not everywhere. Sometimes there isn't a local partner with the capacity or capability, or local relationships may not be strong, so we need solutions that are not bound by local geographies. The Hospital Futures Partnership gives us the capacity to commit intensive managerial and clinical leadership to creating the model, bringing all of the real-world innovations we've developed. National scale supporting local services. Where do we want to do this? Well, we don't know. The nature of this service model, a non-geographical chain, means it must be able to go where the need is. It's most likely to be with smaller hospitals or in rural or coastal areas. Supporting their success means getting a lot right. Effective leadership, leading edge service models, quality improvement, efficient operations and procurement, cultural change and partnerships. This isn't about giving advice on those things. That's probably the last thing a challenged hospital needs. It's about real support on the ground, from standardised practice to introducing exciting innovations. Here's Jim Easton to explain more about what we can do.
Thanks, Jim. I'm Jim Easton, the Managing Director of Care UK. The Hospital Futures Partnership combines the best of what our three organisations do, creating the service models we would bring to our partners in the chain. It starts with capacity. We have access to clinical and managerial leadership and support from award-winning teams, and we'll introduce standardised operating models in all key areas. We'll use real models that are proven already to prevent unnecessary admissions and improve discharges, and we'll combine these with highly efficient diagnostics and class-leading elective care. Using simple technologies at scale, we have access to the largest network of clinical call centres in the UK, handling over 2 million calls a year and allowing the application of 24/7 primary care. Then there's innovation in remote monitoring of patients and telehealth in community settings. There's an opportunity for community and primary care integration, applying Northumbria's proven approaches and innovations in working patterns, such as those at Sheffield's 7-day working early adopter site. Our models will sustain clinical viability by using simple technologies to enhance clinical capacity and providing support, advice and telehealth to support local specialties. We'll improve financial viability through world-class procurement and our national clinical recruitment capability, and all of this underpinned by a strong culture, OD and change management capability from all three organisations. We also have the potential to contribute capital and other non-recurring financial investment in support of change. And critically, we have direct experience of mobilising standard operating models in new geographies, including a playbook approach which defines how our service models should be introduced in new locations. This list represents the best of what we do. Now we want to use it together to make our chain work.
Thanks, Jim. I hope you agree it's an ambitious list, but it's not pie in the sky. It's already happening today in the partner organisations. There's still a lot to be worked through, but we do have experience of creating and operating joint ventures and of supporting one statutory body from another, so we understand the opportunities and risks. We are designing the joint venture vehicle as flexibly as possible, enabling the chain approach with local NHS hospitals to be developed carefully, sensitive to the needs of local engagement and accountability. We're eager and ready to start. Once an initial partner organisation is identified, we have rapid mobilisation teams ready to go. They will strengthen local management and clinical capacity and help operational performance with tried and tested pathway improvement in elective and urgent care. Our teams will help financial performance with the application of improved recruitment and procurement methods. They will strengthen quality, improvement and safety systems. And they will build supportive clinical and managerial relationships across the chain to learn and develop in all directions. In other words, our partnership and approach will be bringing to life the idea that the scale and resources of a chain can support sustainable local care. Being national on some things means being local on the important things.
So that's it. I'm sure you can sense our excitement. We're committed to utilising the strengths of our organisations to make this a success. Our unique approach will sustain vital local services and create a chain which spreads. Spread is built into our proposal. Success with initial partners will encourage others to join, building the chain. The Hospital Futures Partnership is a bold proposal that tackles important challenges. Thank you for listening.
Liam Brennan from the Royal College of Anaesthetists. This is the first of our presentations this morning that have shown us a partnership with the independent sector, with Care UK, thank you, with Care UK. Can you tell us how that will work and the commercial sensitivities of how you would go into an organisation, or a part of the country that is, where you do not have reach as Care UK, and how would you work with other social care providers?
Okay, thanks for that. If I ask John to explain how that would work.
So, good morning, everybody. The first thing to say is it's very much work in progress. I think perhaps that came across in the presentation you've just seen. We have wide experience of working in partnership in various parts of the country. So, and we are already at the moment exploring collaborative approaches and various other approaches to the new commissioning landscape, which are throwing up interesting challenges, not least about how everything fits together from a commercial point of view, not just for Care UK, but obviously for other organisations as well. I think at the end of the day, it's as I said originally, it's work in progress and to be fathomed out and to be noodled through. So it's one of those things that obviously everyone will think that Care UK as an independent sector provider is focused upon. The reality of it is we only work for the NHS. We're not a private company in terms of the healthcare we provide, and we are extremely patient-centric in the services we provide. So commercially, it's one of the it is still to be fathomed, but in terms of the care we provide, we've identified partners with which we can work through shared values.
So question just this table here, just immediately there, and then behind, please.
Nigel Guest, I'm Chief Clinical Officer at Trafford NHS. I was particularly interested in your comments about primary care and how you're linking with that and providing a 24/7 service. I wonder if that's through Care UK practices or whether that's in the much broader primary care in your areas.
I think the whole point of the partnership is actually to learn from each other, and work that Northumbria has done across community, primary and social care will be brought into this partnership as just knowledge and expertise. So I think there's elements of work to really be fathomed out, as you said, but really detailed around how we actually physically go and do this. But what we're doing is bringing the strengths from each of the individual partners to address those areas.
Question from the table behind.
Good morning, it's Trevor Clower. I'm the patients rep for NHS England from Nottingham. You say you have local engagements. How deep is those local engagement? How do you go about digging out the street level approach that I'm interested in?
I'm assuming that's for me. We have well-developed patient groups in common with probably many providers around present in the room. Our patient approach has been sort of polished over many years, and it's also contractually prescribed. So we have to demonstrate that we are including patients at the ground floor in all our services. I'm responsible for CATS and diagnostic services for Care UK, and I think it's fair to say that in Manchester, where we provide 60,000 patient episodes a year, it's not an exaggeration. This service substantively changes once every 6 to 8 weeks. Something happens that driven by clinicians in response to patients and sometimes commissioners, but mostly patients. The service changes. It's an organic service and it's a flexibly commissioned service. So I can hand on heart say there is absolutely no question in my mind that we are responsive to the needs of patients, because we see patients on a very regular basis. We respond to patient feedback in a way that there is no other way from our perspective of doing it. So we use all patient feedback as effectively what it is, which is free consultation for the services we provide.
Probably squeeze one very quick question. Sorry.
Yes, good morning. My name is Nick Bray. I'm a patient representative. I've come from Plymouth. Can you give me some examples? You've said about some of the ways that this is working. Could you give me examples of that? Say, this place is working with that place.
If I can start off, clearly we have limited experience of this, but certainly from the Sheffield perspective, our most direct experience, as you've heard earlier in the morning, has been in terms of buddying. We've buddied 2 NHS organisations that are not geographically co-located with us. One is the North Lincolnshire and Goole Hospitals Foundation Trust, which is Grimsby, Scunthorpe and Goole, and the other one is the United Lincolnshire Trust, which covers Lincoln, Grantham, and Boston. And I think that, as you've heard already this morning, there is a lot of mutual learning that goes on in that, as well as the opportunity to implement a number of the things that you've heard described in the DVD. And we've got early and positive experience of doing that.
We need to leave it there, but thank you very much. That's Hospital Futures Partnership. Thank you.